everyone, and welcome to This Explainer. Today we're tackling a topic that every single one of us in emergency or critical care knows intimately: rapid sequence intubation, or RSI. We've all been there, right? The pressure is on, seconds matter, and the margin for error is basically zero. But what's really fascinating, and what we're going to unpack today, is how the traditional practices we learned years ago are totally shifting. Thanks to new evidence and some pretty incredible technological leaps, airway management is evolving fast. So let's get our protocols up to speed.
Here's our roadmap for today. We'll be moving through a chronological algorithm, starting with RSI fundamentals, then initial assessment and POCUS, pharmacology updates, videolaryngoscopy, and finally, confirmation, care, and the role of AI.
All right, let's jump right into step 1, RSI fundamentals. When you're in a high-stress scenario, relying on just your memory is a massive risk. That's exactly why standardizing our approach is absolutely crucial for reducing mortality. So let's ground ourselves in the modern evidence. RSI isn't just about moving fast. It's a rigid, highly structured protocol built on 2 non-negotiable rules. First, we need to secure that airway in under 60 seconds from the moment we push the drugs. And second, we have to assume the patient has a full stomach. That means the risk of aspiration is through the roof. Everything we do in this protocol revolves around that tight time window and that specific latent risk.
Moving on to Section 2, Initial Assessment and POCUS.
When you've got a crashing patient who needs a tube, time is definitely not on your side. Your clinical evaluation has to be incredibly fast and hyper-targeted. This is where structure becomes your best friend. The classic ample mnemonic is still our foundational guide here. You check A for allergies, M for medications, P for past medical history, L for last intake, which is huge because of that aspiration risk we just talked about, and E for the events leading up to the crisis. Literally in under a minute, this gives you a comprehensive risk map of your patient before a single drug is given. But here is where we see medicine taking a massive leap forward. Beyond just looking at the airway or relying on a Mallampati score, point-of-care ultrasound, or POCUS, is becoming an absolute game-changer for predicting a difficult airway. By measuring things like anterior soft tissue thickness or the distance from the skin to the epiglottis, we are getting incredible sensitivity and specificity. We're finally moving away from subjective guessing to objective, millimeter-precise measurements right at the bedside.
Okay, Section 3, Pharmacology updates.
Now, when it comes to induction agents, we all want that magic drug, something that puts the patient under instantly, keeps their blood pressure perfectly stable, and is 100% safe. Well, since that doesn't exist, we have to be strategic. You can't just look at onset speed. Take propofol. It's incredibly fast, sure, but its hemodynamic stability is notoriously low. It can absolutely tank the blood pressure of a patient who's already in shock. Because of this, current evidence strongly points to etomidate and ketamine as your go-to agents for unstable patients. Etomidate is brilliant for cardiovascular stability, and ketamine has this awesome added benefit of being a bronchodilator, which is a lifesaver in severe respiratory cases.
And now for a massive paradigm shift in paralytics. For the longest time, succinylcholine was the undisputed king of RSI because it acted so fast. But honestly, the scales have tipped. Today, if you use a high dose of rocuronium, you get intubating conditions just as quickly. The huge, game-changing advantage of rocuronium, though, is safety. It's a non-depolarizing agent, so you completely bypass the hyperkalemia risks of SUX. And even better, if you hit a nightmare can't intubate, can't ventilate scenario, you can rapidly reverse it with Sugammadex.
Speaking of paradigm shifts, we have to talk about the Selleck maneuver, cricoid pressure. For decades, it was drilled into us that this was absolutely mandatory to prevent aspiration. Well, scratch that. Recent exhaustive reviews have actually demoted it to an optional practice. Why? Because the evidence that it actually stops aspiration is surprisingly weak. And worse, pushing down on the cricoid often distorts the anatomy so much that it ruins your view during laryngoscopy. It literally complicates the exact procedure you're trying to perform.
Section 4, Videolaryngoscopy and the procedure.
All right, the patient is optimized, the drugs are in. Now comes the physical execution. And wow, has technology changed things here. If you only remember one piece of data from this explainer, make it this one. A 2024 randomized trial looked at first attempt intubation success. Videolaryngoscopy hit an incredible 94% success rate, compared to just 71.6% for traditional direct laryngoscopy. We all know that failing on the first attempt skyrockets the risk of cardiac arrest and severe hypoxia. With a gap that wide, videolaryngoscopy is no longer just a backup tool for difficult airways, it is firmly the new standard of care from attempt number 1. Finally, Section 5, Confirmation, Care, and Artificial Intelligence.
So the tube has passed the cords, but as we know, the job isn't done until we irrefutably confirm placement. Listening to the chest or looking for frog in the tube, not enough anymore. Continuous capnography is the absolute non-negotiable gold standard today. No CO2 waveform, the tube isn't in the trachea, period. But interestingly, a recent study showed that placing a POCUS probe on the neck is just as precise as capnography, and it can actually confirm placement even faster in some cases. It's a phenomenal backup tool. Now, with ultrasound and video taking over, you have to wonder what's next, right? We have screens showing us the airway with crystal clarity. But what happens when those screens start thinking for themselves? How exactly is artificial intelligence going to change how we intubate? Well, it's already happening. Machine learning models are currently outperforming our traditional clinical scores by crunching dozens of patient variables to predict difficult airways before we even touch the laryngoscope. AI is being integrated right into video screens to act as a real-time co-pilot, actually highlighting anatomical structures for you. And for training, AI-driven virtual reality is making team simulations so realistic it's basically indistinguishable from a real trauma bay. But here is the critical takeaway. It's super easy to get distracted by high-def cameras, AI co-pilots, and fancy algorithms. Yet, the evidence screams one fundamental truth. No piece of tech can replace human decision-making under fire. Your clinical judgment to pick the right induction agent, your discipline in running the safety checklist, and the hours you put into simulation, those are what actually save the patient's life. Which brings us to a final thought. We've evolved from a standard metal blade to high-definition video screens, and very soon, those screens will actively guide our hands. With AI gearing up to be an expert second pair of eyes during every critical intubation, the real question is this: are our protocols, and more importantly, are we as clinicians truly ready to lead this historic shift in emergency care? It's time to update our practices for today and our vision for tomorrow. Thanks so much for joining me on this explainer, and I'll catch you in the next one.